Now I will start in the name of the Almighty, the most merciful and the most beneficent. So I've given you 5 questions as a quiz form, and then I'll try to answer or report these X-rays with a due limit of time. I'll try to do it, because time management is my problem. This is part 10 answers. The first X-ray was shown to you. 18 years old, had concussion due to the motorcycle accident, admitted in the intensive care unit for observation, suddenly developed shortness of the breath in a very small duration of time. This is the X-ray which was taken out while he was admitted. It is a lying position, decubitus, and this X-ray, the parameters other than that were fulfilled, and you see the trachea here, then the skeleton, the shortness of the soft tissues, all are seen clearly, visible here, normal, and then lung fields, supraclavicular fossa apical zone, the first intercostal space with the first, second with the second, third with the third, fourth with the fourth, fifth with the fifth, sixth with the sixth, seventh with the seventh, eighth with the eighth, and so on. Now this is the haziness. It is non-homogeneous type of obesities, bilaterally present in hemithoracis. Although the cardiac silhouette is normal, it is nothing abnormality which is seen. In comparison with this, means that the heart is normal. Secondly, the fissures, they are definitely not marked, it is totally blocked, which is not oblique fissure, no evidence of transverse fissure here, no evidence of oblique fissure here. And this is what is going on here, is that from the upper to the lower, there is a hyperdense shadow with air bronchogram patterns type of a thing. Here, and here, all this thing. And sparing the costophrenic angle and the cardiophrenic angle. The angles are free as well as epices. These are the reservoirs actually for the vital capacity. They are free of these shadowings. The dome of the diaphragm otherwise is normal. The middle mediastinum, upper mediastinum is normal. Now, the differential diagnosis without scenarios is that it may be acute inflammation. Maybe he aspirated because he was admitted in the hospital and he developed the bilateral pneumonia in the form of what we call as the aspiration pneumonias. It is possible, yes. The chronic inflammation of the lung, because time lapse is very low. The tuberculosis can be present in this fashion. Yes, it may be present. It may present like this. It will be the diagnosis of exclusion in anything in the X-ray which is visible. Anything. Fungal infections usually causing the macro or micronodular type of patterns. It is non-homogeneous radio obesity, non-uniform, so least likely. Tumor and the tumor-like states will not cause this type of shadowings. Either they are macronodular or it is a cannonball type of appearances. And the allergic reactions and the concern about it, the extrinsic allergic alveolitis will cause the thick reticulations, reticular nodular patterns. So it is not extensive allergic rhinitis. Autoimmune diseases can present like this. The thing is again the same thing, that the thick bands of the fibrosis is not seen in this condition, at least likely. Then going for the other one, the parasitic invasions, etc., it is unilateral usually. Loeffler syndrome, for example, as a parasitic invasion or invasion by the paracomonus Westermani, this will not cause this type of a shadowing. Now this means that that is the all shadowings representing the alveoli and interalveolar septa and interstitial spaces are loaded with the fluid, and these fluids come in very short duration of time. Otherwise the heart is normal. This is a case of the non-cardiogenic pulmonary edema will be present like this. The etiology is manifold. It may be just lying down a patient and motorcycle accident, actually because of the head injury. A lot of changes in the other systems can be represented. One of this is the non-cardiogenic pulmonary edema, inhalation of the poisonous gases, etc., or inhalation in a large amount the external pollutants, etc. They can cause this type of the non-cardiogenic pulmonary edema, as well as in cases of near drowning, etc. There are many causes, but here is a really clear-cut cause. So this non-cardiogenic pulmonary edema occurs because of the patient has got the head injury, concussion, and he was lying in the bed when he developed this problem. The management is the same as we do. We go for the SpO2 and PO2, the other investigation, depending upon this, EVGs, pulmonary function test, if it is possibly done. Otherwise, HRCT is sufficient. The other routine investigation should be done always, and then try to manage it with it. You have to remove the fluid from the lungs as quick as you can. So you give the diuretics in this patient, you will supplement with the oxygen with the hand, with the nasal prongs, or better it is given, it is by intubation. It is better for the free delivery to the oxygen should be given. It should be more than 70% concentration. The flow rate should be 3.5 to 4 liters per minute should be given to this patient. And if the patient has the signs of hypoxia, had the signs of hypoxia and hypercapnia, both, it means he is going into type 2 respiratory failure, then he needs the ventilation, and the mode of the ventilation should be positive end expiratory pressure, PEEP, that is called. This is the first X-ray. The second one, a 52-year smoker, a recent history of STMI, perfusion therapy he received. Now he is complaining of nocturnal breathlessness and orthopnea. These are the signs, all signs are in front of you. The patient has a history of the STMI, perfusion therapy has been given, and he had shown some of the major criteria of the congestive cardiac failure, predominant left ventricular failure. Here you see the all parameters of the X-rays was done because he was admitted in ICU. This is the X-ray which is done in the recumbent position or decubitus position, because the first rib, second rib, third rib, fourth rib, it is at the fifth rib touching the dome of the diaphragm. Now look at this condition. There is definitely a cardiomegaly, there is no doubt about it. the apex is downwards like this. On the basis of this finding, the lung fields can be described. The apices with the apex, first intercostal, second, third, fourth, downgoing, and then you see the perihilar shadows here. There are some patchy opacities are visible. Probably he has received the therapy. He was on therapy. So there is a resolving type of the homogeneous opacity or non-homogeneous opacity. The air bronchobalm pattern is seen here bilaterally. So he has, this is what we call as the resolving pulmonary edema, because there are 13 or 14 presentations of pulmonary edema on the X-ray chest. I have described previously when I was taking classes for the final year, and all X-rays I think I have shown them about the Cali lines and etc., the spider appearance, the butterfly appearance, the bat wing appearance, and towering sign, and all these things. There are a lot of radiological markers for the pulmonary edema. Here again it is the fluid is collected in between the interstitial spaces and in between the alveoli, and that is why he is suffocating. Saturation drops. Most probably this is a clear-cut case, although the differential diagnosis can be made by aspiration. Again I will say, the patient was admitted in hospital and there is a bilateral pneumonia or you can say the bronchopneumonia, aspiration pneumonia, although these likely because these parts are compensatory impessimatous. The tuberculosis in any case should be excluded, although the history will not actually supporting this. Fungi will not cause these type of lesions. Micro or macronodular lesions are the most common presentation. Allergic reaction will not cause like this, like for example extrinsic allergic urolitis. Sarcoidosis will not cause like this. Autoimmune diseases have got the reticulonodular pattern in most of the cases. About the parasitic infestations are concerned, no, because it's bilateral involvement, and this is not a classical case of either the what is called as the Doppler syndrome or other the pulmonary eosinophilia is concerned. And about the tumor will not be present like that. It is not just like that because there is no collapse, direct sign or indirect signs if it is a tumor. So the diagnosis is very clear here. It is a cardiogenic pulmonary edema because of the left ventricular failure, acute left ventricular failure. Other investigation you can do the ECG, echocardiography, and clinical examination, and these two investigations are enough to diagnose this. But most of the hospitals also are doing the pro-BNP or derivatives of the brain natriuretic peptide which are raised in this condition. But it is not the conclusive evidence. Conclusive evidence is your examination, presentation, X-ray, and helping hands tools would be the echocardiography and the electrocardiograph. So the management in this case, they reduce the preload by giving diuretics, reduce the load on the heart, reduction of the oxygen demand by giving the beta blockers, and reduce the afterload very quickly. If you want to do it very quickly, the afterload, you can give sodium nitroprusside, and if you want to give gradually, want to reduce the load, give the nitrates, or you give the oral captopril. Now, this is the correct indication of the captopril. Otherwise, the captopril should not be given in the other conditions. 6.25 is the dose, gradually mounting to 50 milligram, or then after taper it up. And you can give this condition, if it is resistant, then go for the inotropes, or you give the antiarrhythmic drug associated with it, and also give coverage of the, for the anticoagulation is concerned, or antiplatelet should be given to this patient. Immediately he can be non-symptomatic when you give this therapy. It is very, the patient will remember you in his whole life that he was shortness of the breath or air hunger, and you have relieved him. Always remember the doctor. The third one is the 43-year-old smoker having the past history of the antitubercular therapy 5 years back, presently complaining of asthenia, lethargy, and shortness of the breath. Now, interpretation is this, that all the bony skeleton and soft tissue shadows, etc., the trachea is central, starting in the lung fields, the apex with the apex, and the first intercostal space comparing the second, third one, fourth one, fifth one, sixth one, seventh one. There's nothing. There are bronchovascular marking which is coming out from the hyla, and this is normal. This is normal. There is nothing visible here. The cardiophrenic angle, costophrenic angle, cardiophrenic angle, costophrenic angle are clear. It means lungs are clear. And clinically it was also clear. I remember that this case was associated with the engorged veins in the neck. I remember this case. About the lower part of the middle mediastinum means that the heart and the membranes look this line of the border. That border is a linear calcification, and the base is linear calcification. This is a calcification with here. This is very important heart data or sign cone of the disease. This is the right border of the heart, and this is upper part of the middle mediastinum. Here, this is the ascending, this is the arch of aorta area, this is the pulmonary conus. It is normal. You cannot find anything. So what is the diagnosis now? A straightforward diagnosis there. There is no condition elsewhere causing this one with this scenario. And that is a constructive type of pericarditis. You can examine this patient on behalf. You can do the other investigation. For example, the ECG and echo will definitely give you the information. Lateral view is helpful. X-ray chest where calcification is markedly seen here. So chronic constrictive pericarditis. It may be possibility the fluids are very less depending on the echocardiography. If the enough fluid is there, go for the pericardiocentesis therapeutic and see what is the cause behind it. So this is the case is described, and the diagnosis is very clear cut. Etiological differential can be made. In this country, the tuberculosis is the cause. Because he has also taken the ATT. But other diseases can cause the calcification. For example, uremia with hemodialysis, very prolonged hemodialysis can cause this condition. Histoplasmus capsulatum infection, prone to develop calcifications in the elsewhere as well in the heart. And it is also the condition will end up as the heart is concerned as a pericarditis, leading to the chronic fibrosing type of the pericarditis. These are the probably etiology of this condition, and the management is depending upon the etiology. If it is needed, the other general measures should be done to relieve this patient from this condition. Because if you will perform what is called as the catheterization studies, square root sign is present. I mean the pressure in the atria, right ventricle, left atrium, left ventricle, all pressure are equally the same. Because heart is compressed all over the XZ axis, X, Y axis, Z axis. So it is encased in the fibrosis. The heart is encased in the fibrosis. So basically, if it is responsive to the pharmacological therapy, giving to the diuretics are given, the cardiac load should be decreased and the afterload should be decreased with this patient, as well as the ATT will be tried to reduce the fibrotic reaction. Ultimately, solution is the gold standard is the thoracotomy and do the decortication here. The fibrous tissue should be removed from the heart. So it should be pericardiotomy should be done to relieve the heart from the pressure outside. This is the gold standard. The fourth one, 14-year-old having the grade 5 panthystolic murmur at the tricuspid area. All parameters are fulfilled: the bony skeleton, the soft tissue shadow of the trachea, lung field, first apex with the apex, second intercostal space with the second. Compare it. Although the only bronchovascular marking are visible bilaterally, touching the lateral one-third. Many congestive changes are seen in the lung. On the lower, there is hypertransparency or compensative emphysema. This angle is slightly obstructed here. Costophrenic angle on the right side. Cardiophrenic angle is normal. Cardiophrenic angle on this side is normal. Very clear costophrenic angle on the left side. The upper part of the middle mediastinum is very, very narrow. You can see here. Although it should be at least 6 centimeter, it is 4 centimeter. But the part of the heart you see is enlarged, just like egg or bag appearance. There is no hilum overlay sign. It is not pericardial effusion. So what is this then? This is left border of the heart, this is right border of the heart. And the cardiothoracic ratio is increased. And the apex is going transversely. It's a boot-shaped heart. In the Latin it is called cor and sabot. Means that the right-sided cardiomegaly is predominant in this condition, and there is increased pressure in the right ventricle. If there is anything causing any congenital abnormality which is causing increased pressure in the right atrium, right ventricle, secondly involving the pulmonary artery, increase the pressure in the pulmonary artery. Look, this pulmonary conus is prominent here. So this type of reaction which is caused by this is called Eyes-Menger's reaction, and the Eyes-Menger syndrome or Eyes-Menger's, which is called the Eyes-Menger's triad, that is the right ventricular enlargement, increased pressure in the right ventricle, and increased pressure in the pulmonary conus. This type of X-ray can be seen with any congenital abnormality with reversal of shunt in the VSD will cause it. The PDA can cause it. Atrial septal defect, secondum type can cause it. So lesion of this type, and another abnormality which is called Epstein anomaly, can cause this type of lesion. Where Epstein anomaly, it means that there is a tricuspid valve which is situated here with a diameter of about 6 centimeters. It is going down, and from the normal position to lower down, and this is called the tricuspid is going down. So it is the atrialization of the right ventricle. The terminology we use is atrialization of the right ventricle, because now right atrium is more, area is here rather than the right ventricle. So right ventricular cavity becomes small, and when it is small, then the pressure will increase. It will increase, then the pulmonary conus pressure will also increase. So this is the Eisbanger's. Because of anything, Epstein anomaly or other congenital abnormalities, it can be differentiated with the echocardiography. That is the best way to do it. And you can also do the electrocardiography to see the other parameters of cardiac functions. All routine investigations should be done with this patient. The management strategy, that is because it's got a pansystolic volume, means that it is tricuspid area is actually lower down and increased, and there is, of course, overriding type of process is going on here. So you reduce the preload by giving diuretics. You give the decreased oxygen consumption to the heart by giving the beta blockers, or you can give the amlodipine, and then you have to reduce the afterload in this patient by giving the angiotensin converting enzyme inhibitors or receptor blockers. Prevent this patient from because this patient prone to develop the infective endocarditis, and endocarditis prophylaxis should be given, and also you give the platelet inhibitors to these patients. Actually, the gold standard is the surgical procedure, whether you are doing for the ASD, you are doing for VSD, or you are doing for the PDA, or you are going to do the tetraplegia fellow, or you will go for the Epstein anomaly, etc. So corrective surgery should be done, reparative surgery should be done. This is the gold standard management. The fifth X-ray has shown to you a 32-year-old cotton mill worker developed remittent fever, cervical labellopathy, loss of the weight, and arthralgia for the last 6 months. Now, in this case, she has a mill worker, cotton mill worker, whether either packing the things or whatever it is, and developed remittent fever. The X-ray is concerned, interpretation, the bony skeleton is normal, only some osteoporotic changes are seen, and the soft tissue shadows are normal, the trachea is normal, but the lung fields here, episis with episis, first intercostal with the first, second, darkening hypertransparency is seen. Low down the bronchovascular markings are coming out, sprouting out from it, of the hyla, but they are not touching the lateral wall. So the cardi is concerned with the, this one, the dome of the diaphragm, costophrenic angle, cardiophrenic angles of both sides are normal. Upper part of the medial sternum, you see the ascending aorta area, the arch of aorta, aortic knuckle, and pulmonary conus. This is normal. The hyla are very prominent. Yes. They are about 2.5 to 3 centimeters from here to here, or here to here. Enlarged prominent hyla, the right hyla upper, and the lower part is the stem of the right hyla. What is important to see is this part, which is not a part of the cardiac shadow, is coming like this and is moving up. This is the trachea, paratrachea. This is the paratracheal lymph nodes, which are seen here, this part. Because the patient has got, you already did clinical examination, the cervical lymphadenopathy, there is perihilar or hilar lymphadenopathy with a paratracheal type of a lymphadenopathy with a fever. The first most likely diagnosis are lymphoproliferative disorders, maybe Hodgkin lymphoma, maybe a non-Hodgkin lymphoma, most likely Hodgkin type of a lymphoma, because it's a centripetal distribution of the lymphadenopathy. Otherwise, the other lymphomas can also be present like this. It is not necessary. So this type of the lymphadenopathies can be seen in the other condition as well. For example, the chronic inflammation, tuberculosis, the fungal infection, many types can cause it. And the acute inflammation, anything like mumps or measles or any infection, viremia can cause it. I have seen this type of lymphadenopathy in coronavirus also, where the acute condition, in an acute condition there was viremia which is going on, or the coronavirus causing the lymphadenopathy or bilateral. So anything which is causing the bacteremia, or viremia, or rickettsia, or mycoplasmia, etc. will cause lymphadenopathy, bilateral. But specifically speaking, the paratracheal group and cervical group are involved. With this type of picture, is more focusing on the lymphomas. So we go for the lymphomas are the most probable diagnosis. And then we go for the further investigation. The HRCT should be done in this patient. The sputum for the examination for the DR and the AFB and gene expert to exclude it, absolutely tuberculosis. And then go for the transbronchial biopsy, direct evidence. You have to take direct evidence, or because there was a cervical lymphadenopathy, take it whole lymph node biopsy should be done. FNA is not helpful. To grade the tumor properly, and then clinically stage the tumor properly, and then go for the management strategies. The tools are the chemotherapy, radiotherapy, and surgery. The surgery is not indicated in this case. Only the therapy with the new antineoplastic drugs, immunosuppressive drugs are combined. C-CHOP or CHOP therapy, etc. are beneficial to the patient, and you can give the radiation as well if it is indicated. But chemotherapy is sufficient in the most of the cases. This is the gold standard management, and patients survived. My 7 patients of Hodgkin disease has survived. Now they are living now, and I have diagnosed 20 years back, 15 years back, 10 years back. They are in good health. She was a lady and she is now alive, and she is just going for the follow-up, that's all. So these are the cases which I have presented. Whether you like them or not, I don't know. The way of presentation of mine, you like it or not, I don't know. My aim was to deliver the knowledge. I have delivered the knowledge. And these 46 or 47 X-rays, if you can remember how to interpret it and how to talk further, then you will be, inshallah, clear this examination. I wish you good luck. Goodbye and good night.